Okay, welcome Scholar alumni and CPCRN members to our CPCRN Scholars Webinar series titled Designing for Dissemination and Sustainability, Defining Your Value Proposition, Ensuring Fit to Context. My name is Ally Hucek, and I am the co-project director for the CPCRN Scholars Program and will serve as the moderator for today's webinar. I will be monitoring the chat, so please put any questions you may have in the chat or feel free to unmute and ask your questions at the end of the presentation. I'm pleased to introduce our speaker for today, Dr. Elaine Morrato. Dr. Morrato is the founding dean of the Parkinson School of Health Sciences and Public Health and a leader in the field of implementation science. She received her DRPH and MPH degrees from the Johns Hopkins Bloomberg School of Public Health. Trained in epidemiology and board certified in public health, her scholarly activity focuses on accelerating the translation of health innovation into practice and policy with a special interest in drug safety. Dr. Morrato's experience spans academia, government, and the pharmaceutical industry. For the first half of her career, she was an R&D manager at Procter & Gamble, where she directed late-stage clinical development and commercialization teams to advance new claims and indications for OTC and prescription drug products in North America and Europe. In the second half, she has been in academia, where her research has been funded by the National Institutes of Health, Agency for Healthcare Research and Quality, and other public and private organizations. As an administrative leader, she maintains an active implementation science research portfolio as part of a multi-institutional collaborations exceeding $75 million in funded work for the NIH, National Center for Advancing Translational Science, and Centers for Disease Control and Prevention. We are so pleased to have her today for our CPCRN Scholars Webinar series to discuss designing for dissemination and sustainability. I will now turn the Zoom over to Dr. Morrato.
Yeah, thank you very much. It's my delight to be here to share, and I hope that our hour together is interactive and you walk away with some tips that you can put into practice right away. So I've tried to make it a bit pragmatic. So let me get started. What I'm going to do is be sharing a fit to context framework that is been in the Designing for Dissemination and Sustainability, sometimes shorthand is D4DS, that has been recently published, and I'll be sharing some materials on it. And what I want us to get thinking about is, if we were to be startup companies ourselves, we are our own entrepreneurs trying to get our interventions used and adopted and sustained. I want to bring in three methods that might help inform a yes and in how we think about designing for dissemination sustainability. So value proposition design, this concept of get, keep, grow for dynamic dissemination strategies and activities, and thinking from the start around what is going to be your business model for sustaining once you've shown effectiveness. And we're going to try and apply this to a real-world case example that comes from the evidence-based cancer control program on smoke-free homes, and using the information that NCI has on their website to spur our thinking. Okay, so I want to thank you for describing background. If I reflect on life, and what you work on, you find that you grab insights and information from the different settings in which you get to be a professional. And what I have found joy in is how to think about the bridging between things I learned in concepts for marketing and consumer brand product development, how that relates to themes of implementation science and rigor, and application, because we work in complex health systems, right? We work in a regulated environment. If you're working on drugs or diagnostics, we know FDA regulates. But if you're working on other guidelines, we know CDC has information, or state laws. And so it's not as simple as just, come with an idea and let's just market it. We have to be operating in that context. And it's at that intersection of these three areas that I think we can be creative. And so why do we have implementation science? By now, you've seen these quotes many times. We know it takes many years to get new knowledge from randomized trials actually into practice. And even then, it's rather uneven. There have been studies that show whether it's an individual patient, let's say on high blood pressure medicine, or physicians who are trying to adhere to guidelines, 1 year later, about half of us aren't following the guidelines anymore or aren't taking our medicines the way we were intended. It's a human natural process. But it's not only what we see in our academic world. This is consistent also with if you were in a startup and you're trying to come up with new ideas and make new companies. Some have reported that 3 out of 4 startups fail. 3 out of 4 interventions, great ideas based on technology and insights, they fail. And when you look at why, the majority of the time it's because they have a great idea, but they haven't thought about, are they designing it for a problem that people really care about enough that they're going to change what they're doing. And so that's what designing for dissemination and sustainability is all about. It's helping us have a framework so that we can traverse what is commonly referred to as valleys of death. That is, we have a lot of research, in this case, government-funded research that occurs in government agencies or in universities that might be basic science on manufacturing or innovation. And yet it's challenging to actually cross that gap into the commercializable, scalable world. For those of us that operate in the Clinical Translation Science Award or CTSA community funded by NIH, this is analogous to what we might call valleys of death of translation. So translation T1 from discovery to a candidate or an idea in health, going to evidence-based practice, health practice, and then population. So we know that this is a human condition or a problem. And so design thinking would say, how do I start to address this beginning with the end in mind? Not to be surprised by it, not to think your design is going to avoid it, but rather this is the norm. So what are we going to do so that we can be adaptive and think entrepreneurially and how we not only design what we're doing, but fit to context along the way? And that's where designing for dissemination and sustainability fits in. And here's the fancy framework, because we know in implementation science, everything needs a framework. But this framework actually evolved out of training for a D&I certificate program when I was at the University of Colorado. And we created a course around designing for dissemination and sustainability. And Bethany Kwan, who's still at CU Anschutz, and I co-created it. And out of that, an adaptation and collaboration with colleagues at WashU in St. Louis and Russ Glasgow, formalized it as you see here. It was a book chapter in the book. It was in an article that you can click to. And WashU in St. Louis has, with their magic, translated it into worksheets and planning as web-based tools I have here. I'm going to show some pragmatic ways that you can start to be working along this on your own. It's thinking about this as a design process from the start, in that we're conceptualizing what we're designing with intentionality around what's the value we're trying to do for whom. We're now thinking about, given that intentionality, how do what evidence is necessary for different audiences? It was mentioned I have done work with FDA. There's clearly evidence you need in order to get FDA approval. But that's not necessarily the evidence you need to get pricing or reimbursement or on formulary. And that might not be the same evidence that you need in order to convince a doctor to switch their practice or to convince a patient that they should take and stay on the medicine. And so by thinking of this as a design process for each one of those different customers, you start to think, what's the evidence I need for each one? And where can I synergize my evidence development? And where do I know I need to do it sequentially? That then informs your dissemination strategies. And we'll talk about this in a minute. I often think of it as, where is that gap between what's currently believed and what you need to have believed, your assumptions, in order for someone to adopt what you're saying or what you're proposing? A good way to think of it is, if we went back 40 years ago, people might say, gee, I'm not sure if I need to be treating cholesterol. It seems like a surrogate endpoint. What's the so what? I don't know if I should be giving medicines for it. That took a lot of dissemination and what we might say market shaping to show there is a value. It's primary prevention, secondary prevention, and it's really the LDL that we should focus on. All of that is dissemination. It wasn't just disseminating, we have a new drug, but it's thinking about the context and how we shape attitudes and beliefs so that the new idea can be received. These all fit into a strategy. And then it's thinking about the impact you're trying to do. How am I going to sustain this? Now, if you're a company, you're naturally thinking it. I'm going to sustain it by selling things and making money. I'm going to commercialize. And so sometimes in academics or in public health, we go, well, we're not that. We're different. We're in academics and we're in governmental. But we have the same problem. We still have to financially sustain our idea once we show it works. And so what we want to be doing is thinking about that problem from the beginning. And this concept of fit to context is listening along the entire development process to what I'll refer to as your customers, the people that are going to be making the decisions about whether to adopt or whether to pay, and really listening to their context, their problems, so that what we're designing is solving a problem that they care about, okay? And so beginning with the end in mind, if you go to the toolbox and toolkits, there are 3 areas that I'll be talking about. That is, how do we develop something that meets needs? How do we plan for active dissemination, knowing the context in which we're disseminating in current beliefs? And then how do we start to think about sustainability? And even though we're not going to commercialize in many cases, we need to be thinking about sustainability from the start, not at the end when we go, now what do we do? Our grant has ended. And so I'm introducing some methods that come from, you may have heard the term lean startup. This was popularized by serial entrepreneurs coming out of the Silicon Valley and associated with Stanford. And that's this very rapid iteration tool kit that says, how can we rapidly iterate on these questions at each of these stages? So I'll be introducing a value proposition statement, this get, keep, grow as a way of thinking about dissemination campaigning over time. And that there are frameworks for business model canvas that are thought frameworks that can help inform partnerships that we need to do, or how we think about the cost and feasibility from the lens of the person that's trying to adopt. Okay, at each one of these 3 phases, I'm going to take a little break and tie hopefully what I'm talking about back to something real world, because some of this might sound abstract. And the real world case example is coming from the NCI's evidence-based cancer control programs, where they have a catalog of all of the wonderful evidence-based programs, and we're going to be focusing on smoke-free homes. Dr. Kamm-Scoffery and Emory team were key leaders in this, and I hope as she joins us later, she can be our expert in residence. But we want to be thinking of our own wisdom and saying, what would we do? So here are key articles. If you scan here, you can be looking at the materials that are on the NCI page. And you can see that this is an excellent intervention, great research integrity, great dissemination capability and scores. And maybe, as was assessed by peer reviewers, intervention impact and question around how might we get greater impact with it. And that's where we can put on our design thinking hat, and we'll be pausing along the way to say, what would you do if you had to advise the team on how to further strengthen its D4DS plan? Okay. So let's start first with the lean startup approach on value proposition design. We are trained as academics when we write our grants, whether it be for CDC or NIH, that we think of significance, and we think of it through the lens of societal significance, incidence, prevalence, mortality, economic disparities. Investigators out of WashU and St. Louis have termed this translational science benefits. But what we also know as behavior change specialists is that that's important from the policy lens, but for our own individual behaviors, it's our personal motivations. It could be a functional benefit. I can do something faster, easier. It could be a social benefit. I fit in with my peers. It could be an emotional benefit in which I feel good. And this is where value propositions come in. And this is where good marketing, good advertising taps into that emotionality. So there's a training program that has been developed out of National Science Foundation and then adapted at NIH called the I-Core, which is Innovation Core. It is a rapid iterative value proposition design training program in which you conduct In the small courses, maybe 25, 30 interviews, and in a large course, 100 interviews to build out your business model. But at its core is taking that listening learning and putting it into a hypothesis statement that can then be validated. And just like any hypothesis statement or SMART objective, it looks simple until you try to fill it out. And that's where it takes teams and iterating. Really thinking about who's your target very clearly, what's really the problem that is, as they'll say, pants on fire, not just a nice to solve problem from their perspective. What is it really providing them? How are they defining your competition? What other things could they be doing? And that makes us oftentimes feel uncomfortable because we don't like to think about ourselves as competing behaviors, but that is in essence what's happening. And really being clear of what is our main benefit. We often write all of the wonderful things that we can do, but if you could only say it succinctly in an elevator, what's the one thing that's going to drive someone to change their behaviors? And the I-Corps thinks about it, not just, let's say, an intervention that was developed for a physician, for a patient, or a public health agency for the public, but all of these are customers or partners in these, we operate in a complex healthcare system. That is people who are purchasing healthcare, people who are paying healthcare, policymakers that are defining what is payable or not. Product makers would be manufacturers. It's not just academic public health, but there's companies that are trying to solve similar problems. And then there's, because we had to have another P, principal investigators, but this really stands for the whole academic research community. But another way to think about it is to frame each one of these people in a lens of who's the end user, who is the economic buyer that's going to determine whether or not something is going to be tried and repurchased and reused, who ultimately is the decision maker, might not always be the economic one, and who's going to care and influence whether or not it does get adopted, or in some cases, be your saboteur, meaning they're going to not be so happy that you're trying to get something through. So like in tobacco, it's very easy to say industry is not going to always be happy if we're trying to do smoking cessation. But sometimes it's not so obvious. Let's say you're trying to do an intervention to save drug costs in a hospital, or device costs or overutilization of testing. But if that's a main economic driver for that hospital system, now you're at competing odds. What might be good for society might not be necessarily good for that individual hospital. And so the process is really getting to think through who are all of these players, all of these actors or customers, and thinking of the problem from their lens. And I'll give a couple of examples because it's easier to do this with real world. A classic one, if you go back in time, it relates to toothpaste. Back at this time, Crest, the brand manager for Crest, saying, how am I going to get people to purchase Crest? There's lots of toothpastes that have fluoride. Fluoride's good. Well, their insight, the economic buyer for families at that time for toothpaste were the female head of household. What motivated them as a pain point was their child's first dental visit. That child's first dental visit was occurring somewhere in preschool by the time they're in kindergarten. What they worried about, yes, they wanted no cavities, but what they worried about, they didn't want to look like a bad mom, like you weren't taking good health of your child. And they didn't want their child to get bad information from the dentist. That doesn't feel very good. It's like getting an F on your report card. And so the insight was for moms of 3 to 5, the economic buyer, who want their child to be happy and also don't want to look like bad moms, Crest provides cavity-free protection. And why is it unlike others? Well, it has the American Dental Association seal of approval.
How are you running?
And at that time, no one else had that. So it was first, it sounded novel. Maybe in today's world, we're a little jaded by those things, but back in 1962, that meant a lot. And then they translated into beautiful copy that just felt very emotional, right? I'll give one that's more of a hard science one that I experienced. This is a drug that's used for ulcerative colitis. It's sulfa-free. It was the first product that didn't contain sulfa. About 15% of people have sulfa reactions, and maybe about 1 to 3% is pretty severe. So doctors knew about this, patients knew about it, you couldn't predict it. When it was positioned as, this is great, it doesn't have sulfa, doctor said, this is great, we need this. And when did they use it? They used it once the patient had the sulfa side effect. But what we really listened to was the pain point is the unpredictability of knowing when they have not knowing when you have a sulfa side effect. It could occur in off hours, it could occur on your weekend, it could get in the way of your time managing more serious things you're having to attune to as a gastroenterologist. So when the value proposition switched to avoid this unpredictability, this hassle of managing your patients, suddenly the concept changed. And what went from a 15% uptake or market share turned to about a 70-75% change. So I share this to say, even with things that are existing and have value, it's listening to where's the pain point and thinking on how best to describe. So in the case example, we talk about a safe homes, they're framing it also, what is the value of the parent and trying to protect the health of their child. So very similar kind of position. So good value proposition statements, they target and they think about who's the customer, who's making the purchase decision. They articulate what's something that's a tangible, immediate benefit. How is it helping you right now? Like weight loss stuff is not like, yeah, I know I need to have low weight or healthy weight, I should say, so that I don't get cancer or I don't get a cardiovascular disease. Yeah, that's way down the road. That's a very different motivator than saying, I'm getting ready for my wedding and I want to lose some weight, so I'm healthy, so I look good in the short term. Those are very different motivators, and it's really how do we listen for the things that are important. And I know many of you who do behavioral health promotion, this is already kind of baked into your DNA and understanding. It's just now thinking about it as a dissemination strategy. And then this gives you a hypothesis and you validate it, but it's a starting point. So if we look at our example, and I'll ask a question in the middle around smoke-free homes, the good news in this context is, the majority of the population is covered by some smoke-free laws, largely applying to where we work and where we eat. They have a lot of high public support, and it's increased over time, but there's still variation. And so where the gap is here is there are disparities. People who live below the poverty here, people who are at home and live with someone that is smoking. So you have secondhand smoke there. And this is particularly important for young children. So this is the unmet societal need. And so now you look at the smoke-free homes. And so I took a stab at this. If we put this into a value proposition for public health professionals who want to reduce secondhand smoke exposure for children, particularly in high-risk settings, we might add the smoke-free home intervention has proven results in at-risk communities that have been published in reputable places, and it's on NCI. So unlike the status quo of trying to figure out how to do this own kind of programming, you could take this off the shelf from NCI and apply right away. And so we'll come to this next. So that's how we might do it for health, from the health professionals. The way they targeted it also is from the standpoint of the recipient of the program. So in this case, you had to have both adopting it, right? Someone had to disseminate it and the other people had to say, I'm willing to do it. So for low-income parents who use 221 call centers for local social services, so these are largely low-income, which have a higher proportion of someone who smokes at home, who want to reduce secondhand smoke exposure for their children, our program, Some Things Are Better Outside Assistance, is an easy at-home option. As opposed to not doing anything. Here's an easy to try and delivered at home, and we'll help you out. It's mailed to you and you get a helping hand, someone to call you. So this may be this sounds really good, but if you were to look at it, are there any thoughts on how we might further strengthen this or think about it from the standpoint of through the lens of could we advise them to make it more specific in ways, or what assumptions are kind of embedded in this that we might want to make sure are true? And I'll let people put some ideas in chat because I know not everyone wants to come off of mute. Any ideas? And I'll just look at the chat. And there are no bad ideas. It's a brainstorm. I'll give it a second. Okay. I'll get it started. People might not know how to kind of approach this. So when we say for low-income parents who use 221 who want to reduce secondhand smoke, we have to also be thinking that they did not call the 221 call center seeking smoking cessation or smoking exposure resources, or as I understand it. This was sort of they're approaching social services for other reasons and are getting introduced to this as some way to help. So in here, we need to be thinking about, are they seeing this? Are they aware? This is kind of assuming that they're aware that secondhand smoke at home is bad. And that could be a testable assumption you could explore. When we say children, is it all children? Is it only children that are very young? When we say things are better outside, do they live in a place where they can go outside to smoke? Is the child so young that they're a single parent and they can't leave the child by themselves while they go out and smoke? These are contextual things that we might want to say our assumptions are here. These should be things that we should test or validate around that. But the evidence is showing that there was a high degree of adoption. And one thing that's very strong about this is it's tapping into the emotional piece of parents wanting to do good things for their children and not wanting their children to be harmed. Daniela writes, the active language is very strong. How easy is easy, right? Exactly. What we perceive as easy is relative to things. They're getting things mailed. They're getting a consultation on the phone, and they may have, their heart to do it. But at the end of the day, they're still having to adopt and figure out how to make it work at home. So it could be easier than some things, but maybe they're in a home setting that it's just very difficult. And as much as they want to do it, there are still other barriers. And so by putting this into this kind of framework, it allows you to have the thought experiment about what if, and you can go through each one of these as assumptions and say, gosh, there are assumptions behind each one of these. And it allows you to do more qualitative understanding or observational understanding of that context. One other question is, how many people use 221 call centers? What's the reach of that? It's probably large urban centers. And indeed, some of the early work that was done by the investigators were there. Now, it was adopted in other settings, and we'll talk about that in another moment. And the investigators, you could tell, had a lot of intentionality with trying to create something that could be easily adaptable in other settings, anticipating what that might be. And Danielle is saying, do we know if any differences between getting mail at home versus mail where people still need to pick up at a PO box? Yeah, or, this work was done a decade ago. Are people even getting mail? Or how often? I live in Chicago, and there's some times where I don't get mail every day. And I know my young adult children, I think mail is an anomaly. And I don't, it could sit in there for a long time. Now, maybe that's good, such that when they get mail, it's like, wow, this is something different. I don't get mail all the time. Could go both ways, but there might be other ways that we need to deliver and adapt that would flow into how people are getting information. Okay. So this is, let me just close the chat so I can see other things. Okay, so now we have a hypothesis about how we're going to take our intervention and frame it in language that might be compelling for an individual to say, why me? Why should I adopt? The next one is, how do I think of these dissemination strategies, in which we've alluded to, or started to allude to? And this is recognizing, and I know Russ Glasgow and others have talked a lot about this, is the declining voltage, right? That there are a lot of decisional processes. First, I have to be aware that this intervention exists. I have to believe it and accept the evidence that it's worthy, that it's applicable to me in my setting, that I'm able to do it. We've talked a lot of these already, right? That I act on it, and then I'm willing to keep doing it, right? So how many of us have tried to change a habit? and you do really well for a few months, and then you kind of go back to your last habit, right? So there's a whole science around how do you habit form, et cetera. And so what that means is you've got to be thinking about dissemination through this entire process, not just raising awareness and not just technical assistance, but sustained dissemination. If you're a company, like a startup or a large company, do they just do one advertisement? No, it's very multi-pronged. And that's what sometimes makes it hard for us in academic research projects. We don't have access to the same funding level that is often necessary to be operating at scale. I think one program that is exemplar in this area was the Truth campaign for the Tobacco Legacy Foundation. They went after the problem at scale. They had funds to do it, but they approached it the same way a very large marketer might. But we need to at least be thinking these steps. And as you are disseminating, this changes over time. Where is your target customer right now? Where is the audience you're trying to disseminate? Do you know how many of them are on this continuum? And therefore, what might be their barrier or objection or question to whether or not they should be adopting? And therefore, this information is important as you design your dissemination messaging. Okay. And then you hope that you have great brand awareness. One thing that was really nice about the, tobacco-free or smoke-free homes is they had a logo, right? Everyone is hoping that you develop a logo such that you don't have to have all of the story. You immediately know what it means. And it doesn't, in America, people can tell, without even seeing the full logo. You're just seeing the colors and the shapes. You know this is McDonald's. And so think about great brand advertising. How can you be getting brand advertising for yourself in the interventions you're doing? It's what WashU is doing by having a D for DS planner. That is branding. And so oftentimes we wish we had a marketer on our team, and that's not always very easy, but there's a lot of free information out there. I just went and Googled this and just said, what are some brand awareness strategies? And so you can just go to some of these tricks and, how might this apply to a multimodal dissemination strategy for the work that you're trying to do? And which one of these channels is most relevant given the audiences you're working with? And pick and choose from there, as a way to get started. It's also recognizing it's not just the channels you're doing, but it's recognizing also that individuals have a natural propensity as to where they put themselves on this diffusion of innovation. So diffusion of innovation is a time-based process. So this is why you have to have sustained marketing or dissemination campaigns over time. The early people, if you've read Tipping Point, or if you've read the Diffusion of Innovation seminal work, we know that innovators, and many of you in this audience are innovators and early adopters because you're already working in academic sites. We say, yay, shiny new thing. Yay, I want to have one of those too. Yay, I want to be the first one getting that R01 that's doing this, right? We're willing to take risks. We're willing to just go and create. But the evidence that we find most important is the work that says we get to be first, and we get rewarded for being first, right? The middle crowd, the majority, is motivated by pragmatism. It looks interesting, but I'm not quite sure it's going to work here. Those are some strange people in those academic campuses. What is this really going to be like for me in the community? And that's why it's so important what CPCRN is doing, which is trying to translate the academic to the practice and back and forth so that the innovator people are being informed by what the majority really care about. Because it's too easy to say that's too different and that's too weird. And then there's some who will just not, we can say laggard, but we might say they're skeptical. I've seen a lot of that come through before. It's just a fad. I'm not going to, I don't know if I trust this stuff. And so individuals are naturally inclined towards there. And what's really fascinating, I think, is that it's different evidence and different motivators. It's not like one dissemination package is going to solve all of this. And you have to be thinking about this sequentially. The risk taker wants to see the novelty. They're okay with it not being fully worked out. In fact, they want to be the first ones working on it. That is an appeal to them. They can make the mental leap. And probably being invited and included is enough to do that. The pragmatic people are looking for ease of use and convenience and efficiency. They want to see that it works in places like mine. And so the smoke-free homes, what was really nice in that is the first 3 articles were in 3 different states and settings. It was Atlanta, it was North Carolina, it was Texas. So it's showing it can work in lots of places. And ideally, that the last ones, skeptics, sometimes, let's just say smoking policies, it's I'll do it when it's required. I have to have proof. I have to adopt it. Authority dictates. And so to get these sometimes requires laws and policies, not just interventions. And we've seen that when you look over the course of smoking tobacco policy, right? Risk takers knew I should stop because I saw this, U.S. Surgeon General report. Pragmatic was, the pricing and the taxing is not something I really want to deal with. Maybe this is my motivation. And the skeptics are like, not until you put in the laws. Now I have to comply. So you have to think of this as a temporal strategy. And different evidence will be needed at different stages. So really think about where you are given what you're trying to diffuse in that. The get, keep, grow is dissemination is not a one-time event. It's not, ta-da, I disseminated. In marketing, it's very different strategies of engagement are needed to acquire someone to start using it, to activate them, to prepare them. That's like the technical assistance to help them. And then you need a lot of strategies to keep them engaged. And you know that when you work with community partners or any partners in health systems, it's the engagement, it's the ongoing relationship that is in itself a dissemination strategy. And so some of these things are listed more in business terms, but what are you doing for continuous outreach and engagement and community building? And how are you thinking about new innovation coming down the pipeline so that in business language, you'd say you're upselling, you're next selling, you're that, but it's how do you keep innovating so that they're engaged in wanting to be what's next? How do you expand it, et cetera? Each one of these is a viral loop back in terms of proof of concept, social proof of concept, such that you hopefully get more acquisition. The earned and paid media, what does that mean? Well, sometimes you have to advertise by paying. Could be on a website, could be, going to conferences, could be being on, things like a webinar. And sometimes it's earned when others invite you to be part of that webinar. I've earned it in disseminating this. I don't have to pay in order to be part and create my own webinar, right? So it's thinking about how do I get natural ways of disseminating it that are cost-free, and sometimes you have to, invest as well. Procter & Gamble conceptualizes this as each time someone is repurchasing or agreeing to keep using, it's different moments of truth. And you have to, as a marketer, be engaged at every single place. The moment of truth when people are searching out information about what to do or products to use or interventions. The moment of truth when they're deciding which one do I want to use. And then the second moment of truth, they've tried it and it's like, I don't know if I should continue using it. And so you can see each one of these requires a different kind of marketing message, different kind of evidence. That is the sustained advertising that we really need to be promoting from a D4DS lens to sustain interest. I provide an example here that how I've tried to apply this in an academic setting. I'm a part of a national consortium looking at electronic health record data networks across the Clinical Translation Science Award or CTSA programs at academic campuses. There's about 50 to 60 of them. And we can't get end user researchers using these data networks unless the CTSA hub institutions choose to adopt and data share. And so we have to show value for the adopting agency as well as the end user. And so this is how we've tried to think about that in a strategic way. You could say, we know this in public health. Sometimes you have to go through other agencies in order for them to disseminate and then for them to activate and engage our end population, right? So both of these are dissemination. So at key stages, it requires different evidence. And active dissemination is sustained engagement and evolving over time because the external environment and context and comparators are also evolving. So dissemination is very active and requires careful consideration. So smoke-free homes, I pulled this. This was not all that they did, but this is showing how they've tailored dissemination materials that would be helpful for the agencies as they're disseminating to the end user or the potential person that's wanting to have a smoke-free home. Any thoughts on things that you've seen in tobacco that might relate to this concept of how we're thinking of dissemination multi-level? For those that are very knowledgeable and familiar with it, any insights or pearls of wisdom that you have found as you've thought about this as like a multi-level dissemination? Or people who, thinking about just dissemination generally right now, the trends that you're seeing. If you could put your thoughts in chat. And again, we might not have. Okay, great. I'm seeing some other comments around the previous one. Cultures and communities might not see the problem. So you might say naturally, have you thought about cultures and communities in different ways that they are thinking about it and communicating about the issue? So dissemination to reach, for instance, I did work in collaboration in Colorado with the Center for American Indian and Alaska Native Health. And a lot of their translation for, let's say, the diabetes prevention program was working with local Native communities and saying, what does this mean for them? And it turned a lot into family and the meaning of intergenerational health for their children and wanting to role model that. So thinking about that kind of messaging, not just the average. Okay. So communication, we need to consider communication principles. Okay. And I'm going to move now to my last segment. And that is, what do you do for business models? We often aren't trained in business models. We don't think of ourselves as doing business. We're doing public health, or we're in, higher ed. We're not doing a business model, but higher ed has a business model where we are, and it's about teaching and revenue from tuition or research. And so you too need to learn these skills if you want to sustain. It's not just about this idea of a problem and a solution fit and value. You've got to be thinking about, well, how big is the problem? Is there enough of a market that someone's going to care about it such that there is an economic buyer that wants to care about it, whether that's a local level or a state or federal level? And then what's going to be the business way that money's going to transact such that we can sustain the work? Even if it doesn't mean we're making a profit, we still need to financially sustain it or get it incorporated into a budget. And this is where we have to learn this concept of pivoting, that over time we might need to change the direction of our product in order to continue to adapt to where the need is and who's going to buy. A great example, if you think of the last, 15, 20 years in Apple products, what went from just music and an iPod to a really cool handheld phone to multiple cameras, evolving now to artificial intelligence baked in, right? And so the goal here is still the same, bringing best user experience, through their innovative hardware, software, and services. But how they're delivering it needs to evolve. So to sustain, it might take many years to generate the evidence. And so we still might need to adapt it, what we're doing, to fit the modern mode of communication. And what we may have shown that worked 15 years ago, we might need to use new technologies. So one is new technology adaptation. I'm not going to go through all of this. I'm leaving these as slides. If you're curious about it, you can see it. There's lots of different thought experiments here and thinking about other pivots that you might need or want to do and how you think about it. I'll give you just an example. You might be a practice-based research network, and you started out as research, but you are a network, and actually they care about the quality reports coming out of the network, and they're willing to pay for quality reports because they have to turn in quality reports because they're a FQHC. And your practice-based research network just made that very easy for them. So I joined the research network because it was curious and it was fun and interesting, and I like to be engaged in that. But now I'm willing to pay to participate because you're giving me a product I can use to take away a pain point of doing these quality reports. And so there are different strategies, and you can be sitting down right now in the beginning and just saying, gosh, might there be some examples or models for products or programs that are similar to mine that I can think about? Sometimes it's a platform that you can repurpose in other ways. We're very good at taking an idea and repurposing it in other grants. But sometimes you have to be thinking about it, not just going from a grant, but maybe there's a business opportunity here as well. And so that's where the business model fits in. You can think about this in a business model canvas way. That's actually thinking about the value I'm creating, who are the relationships I need to develop, who are the key resources, who are the partners, who are the influencers. I now think about this as a campaign development over time. I start to think of the cost structure, what's the revenue I might have, and you put it into this thought experiment. You click here, there's one that is geared for more mission driven as opposed to profit motive. But this is a great tool to just thought experiment around, and there's a whole book on it. And if you go to Strategizer, there's a lot of free services there that you can self-study on. Okay. And it's really the value proposition fits there. You're thinking about your channels and communications, and then the activities you have to do. And last, I'm down to the last couple of slides here. What is the financial business model? And there are some common ones. We know that there's our service delivery model. You might have technical assistance. I help you, you pay me for a fee, and I come and help. That could sometimes be supported by states who want to offload that or outsource it. Sometimes we're really lucky and we get our idea into a public taxpayer funded thing. That is like really great, right? Because now it's kind of baked in. And sometimes you have to work in partnerships with others. So there are a lot of examples here. One I'm particularly proud of is my area of work is how do I bring implementation science into FDA? And so for me, getting this into FDA guidance for industry is my way of sustaining it and spreading it and the impact. And what looks like simple logic model for us, because we do it all of the time, had to be translated into this audience. And so you can see that. Another way is to actually go through this kind of training that is offered by NIH. And you think about it as a commercializable product. You can look there for more resources. And sometimes you see non-traditional partners. And sometimes they make us a little uncomfortable. You have to be making sure all of the ethics line up. But in this particular case, the Clinton Foundation, American Heart came together as an alliance for healthier generation. They wanted to take out sugar-based drinks out of vending machines in schools. This was during the Obama administration, in which the First Lady was very interested in these health things, and the American Beverage Association said, we need to come on board. And because they came on board, within 2 years, they had over 80% of all of the high school vending machine contracts changed and moved away from sugar drinks to non-sugar. Now you could say they're still selling, they're still making money. The schools make a lot of money on that revenue too, but it all coming together actually drove that adoption much faster than if we in public health had probably tried to do it state by state or school by school. So the key takeaway here is these are thought experiments. You can sit down and brainstorm pen to paper. It doesn't, and just start thinking from the beginning, because you'll realize, gosh, there's a partnership I think I want to create, or maybe there's some data I need to be collecting that's going to be important for that particular person that might want to pay for it. And so in the smoke-free homes, they worked with different partners. They showed it in different settings, smoke-free cars. They went through other agencies like Catholic Charities. And part of their business model was, you know, getting it listed on the NCI site and providing ongoing technical assistance. So there are ideas that we could kind of work with them and think of other ways. And there's work that continues, and that's why you have to continuous market surveillance and understanding to understand where barriers are, enablers, and continue to adapt. So here's the takeaway, you know, who's your target audience? How are you providing value to all of the players in our complex decision systems? How are you thinking about it, not just getting them, making them aware, but keeping them and growing them? How are you helping them be part of the viral marketing for you? And how are you going to think about sustaining it once you have the evidence? And we think sequentially because we're trained like, gosh, you shouldn't disseminate and implement until you have the evidence. But you have to almost assume you will, such that you can be generating the right kind of evidence so that when you get to that stage, you're helping to facilitate the process. So I'm going to stop there. I probably have 5 minutes left, but open to questions or comments or thoughts. And you know, I used your case example that you so nicely suggested. You know, I don't know if there's any pearls of wisdom you found if you're online here that along this line of trying to think of sustainability.
No, I thank you for using that example. It's actually a nice work of cross-center projects. The program was developed here at Emory, but we had other sites replicate it, as you mentioned, North Carolina and Texas. And, you know, I think there's been some nice dissemination partners like California Tobacco Program adopted it and integrated into their services. And, you know, also thinking about other dissemination partners without it being yet another grant funded. So I think a lot of the points that you talked about today are important. And we were delighted it got onto NCI's evidence-based practice, one of the listed programs. So again, that other people can find it. And if they want to get training or, you know, learn about the nuts and bolts, as you said, you know, you have to have a commitment, I guess, for some programs for them to be in existence, to have that ongoing technical assistance. So we're learning along the way about this process. So just thank you for highlighting it.
Yeah. Betsy, I see your hand up.
Yes, hi. I'm having problems with my computer today and my mouse, so I apologize. I can't figure out how to get my camera off, but thank you so much. That was a wonderful, wonderful talk. Question I had for you is that many of us work with in resource constrained settings to address, you know, issues related to health equity. And of course, you know, many of our partners do see the value in that. Personally, I have found alignment with mission kind of to be the one hook, which is, of course, a CFIR strategy. I would love to hear your comments on just kind of the overall comments about working again to address health equity issues using this kind of perspective. And if you had any other thoughts about, you know, how we can be better sellers of alignment with mission or other things you think work in these settings.
Yeah. So I guess what you're identifying is that there's a target customer, a group of people where we're seeing disparities in their adoption of what might be a good behavior or a good, is that what the product you're disseminating?
Right.
Yeah. So let's say cancer testing or colon cancer testing or screening, let's say. So what I think I would start with, like, the value proposition. All right. So for that particular community, what is the hook? You said, you know, for either the service delivery groups that are trying to meet the needs of that group, of those people, and the people themselves. And thinking about what's motivating to them to, you know, to really understand why they're not doing. So you're probably already doing that, because I know you do that in listening. And so it may be just a pen and paper, you know, a way of saying, how do you take your learning and just reframe how you're talking about it as what the value, you know, is. So I think you can do all of this as thought experiments, just using the wisdom of your knowledge and experience as a group. and then strategize around. You don't have to have a Super Bowl ad, size campaign. It can be just finding out who is your community you're working with, where do they turn to for information, who do they consider credible. I mean, if you think of interventions that are done in churches or barbershops, or in this case, this was 211 centers. Those are places people are naturally convening. How do you leverage that natural way people are having those channels? Now, I guess maybe you're embedded in your question around, well, someone's got to pay for it. And so that's the framing of what's this problem of having health inequity? How does that show up as a problem for the payer? Maybe it's a state public agency, and then therefore you're trying to say, what's the magnitude of this problem to them? And sometimes that requires different kind of work to show magnitude of the public health problem.
Great, thank you so much.
Yeah.
As we wrap up today, I just wanted to thank you, Dr. Morrato, again for this amazing webinar. And I put your contact information in the chat. And we will also be in touch within the next week or so with the link to this recording, and any materials that Dr. Morrato wants to share. I'll provide those in the email as well. And just thank you again. This was great, and I learned so much today.
Yep. Happy designing for dissemination and sustainability.